Today we are trying to learn another important topic in anesthesia, that is arterial supply of the heart, venous drainage of the heart, areas supplied by coronary arteries, and ECG correlation in ST elevation MI. So this is how we draw heart in its anterior view, and the structures you see here are the right atrium, right ventricle, left ventricle, and this one is the anterior atrioventricular groove, also known as coronary sulcus. This is the posterior atrioventricular groove, the posterior interventricular groove, and the anterior interventricular groove. Coming to the posterior view of the heart, the base of the heart is formed by the atria and the ventricles form the diaphragmatic surface. Here we are making a bigger diagram of the anterior view of heart. What you can see here are the right atrium, the right ventricle, the left ventricle, the anterior and posterior interventricular grooves, the posterior atrioventricular groove, and the anterior right atrioventricular groove. The structure you can see here is the ascending aorta and the pulmonary trunk. We have three aortic sinuses. They are the right aortic sinus, the left aortic sinus, and the posterior aortic sinus. The right coronary artery arises from the right aortic sinus, and the left main coronary artery arises from the left aortic sinus. The right coronary artery originates from the right coronary aortic sinus, one of the three aortic sinuses located just above the aortic valve. It passes anteriorly and to the right, running between the right atrium and the pulmonary trunk. The right coronary artery travels inferiorly and posteriorly in the right atrioventricular groove between the right atrium and the right ventricle. The right coronary artery gives off multiple anterior, marginal, and inferior branches, which may include the conus branch, the SI nodal artery, right ventricular branches, acute marginal artery, AV nodal artery, posterior descending artery, and posterolateral branches. But we will only be talking about a few important branches here. They are the atrioventricular nodal artery and the right marginal artery. The atrioventricular nodal artery arises from the RCA, that is right coronary artery, in 85% of the people with right dominant circulation, and in 10 to 15% of the people it arises from the left circumflex artery. These people have left dominant or codominant circulation. The area supplied is AV node and sometimes the proximal part of bundle of his. The right marginal artery arises from the right coronary artery, usually in its mid portion, as it travels through the right atrioventricular groove. It branches off the RCA along the right heart border and travels inferiorly and anteriorly towards the apex. The right marginal artery stays superficial on the right ventricle. It is usually visible on the anterior heart surface during surgery or dissection. The area supplied is usually anterior wall of the right ventricle. The left main coronary artery arises from the left aortic sinus, just above the left cusp of the aortic valve. It is a short vessel, usually 2 to 3 centimeters in length. It runs anteriorly and slightly to the left, passing between the left atrial appendage and the pulmonary trunk. The left main coronary artery bifurcates into two main branches. They are the left anterior descending artery or LAD and left circumflex artery or LCH. The LAD originates from the left main coronary artery after it bifurcates. It runs anteriorly and downward in the anterior interventricular sulcus, and it travels towards the apex of the heart. Therefore, it is also known as the anterior interventricular artery. It gives off diagonal branches and septal perforators. The left anterior descending artery usually terminates near the apex of the heart, but in some cases it may continue around the apex and anastomose with the posterior descending artery, especially in left dominant circulation. Usually it lies within the anterior interventricular groove and is covered by epicardium and fat. It is usually divided into proximal, mid, and distal LAD, and when there is an occlusion in the proximal part of LAD, it is known as the widowmaker artery. The left circumflex artery arises from the left main coronary artery LMCA after it bifurcates. It travels leftward and posteriorly in the left AV groove. The LCH curves around the left border of the heart towards the posterior surface. In left dominant circulation, the left circumflex artery continues as the posterior descending artery on the posterior interventricular groove. The LCH may terminate on the posterior surface of the heart. If the heart is left dominant, the LCH gives rise to the PDA. If the heart is right dominant, the PDA arises from the right coronary artery instead. The occlusion of left circumflex artery can lead to lateral or posterior wall MI. The left marginal artery arises as a branch of the left circumflex artery. It courses along the left margin of the heart, running downwards and anteriorly over the left ventricle's lateral wall towards the apex. The posterior descending artery arises from right coronary artery in 85% of the people, so it becomes a right dominant circulation. In 8 to 10%, it arises from the LCH. It becomes a left dominant circulation. And in codominant circulation, it is both from the RCA and LCH, that is 5 to 7% of the population. It runs inferiorly in the posterior interventricular sulcus between the right and left ventricles on the diaphragmatic surface of the heart. It gives off interventricular septal perforators and occasionally small branches to the posterior left and right ventricles. The area supplied is posterior 1/3 of the interventricular septum. The right coronary artery supplies right atrium, right ventricle, inferior part of left ventricle, posterior 1/3 of the interventricular septum, SA node, AV node and AV bundle, and the interatrial septum partially. The left coronary artery supplies left atrium, left ventricle, left and right bundle of his, anterior 2/3 of the interventricular septum and apex of the heart. The apex of the heart can also be supplied by right coronary artery. Areas supplied by the left anterior descending artery are anterior wall of the left ventricle, anterior 2/3 of the interventricular septum, apex of the heart and small part of the right ventricle. Sometimes the conus branch of the LAD can supply the right ventricular outflow tract. The left circumflex artery in a left dominant heart supplies the posterior 1/3 of interventricular septum, inferior wall of the left ventricle, AV node and SA node. In a right dominant heart, it supplies the lateral wall of the left ventricle via obtuse marginal branch. 40 to 50% of CAD are due to diseases of LAD, 30 to 40% may be due to RCA, and 15 to 20% is due to LCH. A quick word about the venous drainage of the heart. Venous blood is drained into the heart via coronary sinus, anterior cardiac vein, and venae cordis minime, that is the Thebesian veins. Coronary sinus lies in the posterior part of the atrioventricular groove. It drains into the right atrium. The tributaries are great cardiac vein, middle cardiac vein, small cardiac vein, posterior vein of left ventricle, oblique vein of left atrium or vein of Marshall, right marginal vein and left marginal vein. Anterior cardiac vein, they drain directly the right ventricle into the right atrium, bypassing the coronary sinus. And the Thebesian veins, they are microscopic veins that drain directly into all 4 chambers, mostly right atrium and ventricle. They are important in coronary circulation shunting and oxygenation inefficiency. Coronary sinus accounts for 85% of venous return from the heart. These veins do not have valves except the Thebesian valve at the coronary sinus opening, which is rudimentary. Blood flow in the coronary veins increases during diastole as myocardial compression during systole decreases it. Now we will try to have a general idea about localization of ischemic area in ST elevation MI. In case of leads V1 and V2 showing ST elevation, the affected myocardial area can be a septal area and occluded coronary artery will be proximal LAD. In case of V3 and V4, the anterior part of left ventricle will be affected and the occluded artery will be LAD. V5 and V6, the affected area is apical, distal LAD, left circumflex or right coronary artery is affected. In case of 1 and AVL, the lateral area is affected and the artery occluded is left circumflex. In case of changes in 2, 3 and AVF, the inferior part is affected. It can occur due to changes in right coronary artery in 90% of the cases, and in 10% it can be due to occlusion of left circumflex artery. In case of V7, 8 and 9, the posterolateral area of the myocardium is affected and the occluded artery may be right coronary artery or the left circumflex artery.